and then a government program will work.
I think this could be another aspect to it. Maybe a lot of our guys are not opting for pediatric cardiac surgery because there are not too many centers available to work. If you have a large volume of patients and, it's kind of both sides. So if you have large volume and then the patient is not shied anything and they are willing to go to a private and this thing, they would actually go, the numbers would increase. And maybe we would have a more pediatric cardiologists and surgeons and units.
Quite
both
true.
Sides, actually, both sides.
Both ways, like you said.
So we have around 22 participants, sir. We can start. I don't think now we need to go for a introductory thing. We can straight away start with Dr. Manoj Rohit. Or Dr. UP Singh would like to introduce that subject. The subject is also new for us.
I think we are catering to new subjects, and I am also as novice as you are, for that matter. And Dr. Rohit, Manoj, is somebody who's very, very wonderful as a human being. I have a very clear benefit now that the patient, those who cannot afford, he's just a call away. And majority of times he would accommodate in next 24 hours and then give you feedback as well. I mean, what else were we looking for? Thanks, Dr. Rohit.
Sir, it's your blessings that we are growing. Thank you so much.
He comes to Raipur also, sir, and he had started congenital and pediatric program here.
Good evening, Manoj sir. It's actually our privilege to have learned from you from PGI days onwards, and you've always been an inspiration. Dealing with adults, dealing with everyone. Actually, it's always an honor and privilege. Actually, it's always nice to learn from you again, and it's again an opportunity. Thanks to Smit and this WhatsApp group. Actually,
thank you. I think Arun, you are doing tremendous work. Thank you. Great going. Congratulations.
Thank you. Thank you.
Start.
Yeah, we should start, sir. Suresh sir can actually.
Yeah.
Suresh sir would be the right person to introduce the topic with so much vast experience. Actually.
So I think we were doing that over the last few minutes. So what Dr. Rohit is going to touch upon is an emerging area of extreme importance in the management of older children and adults with congenital heart disease. With a large number of congenital heart surgery leaving behind conduits that require replacement or native RVOTs that have pulmonary regurgitation, the ability to deal with that problem without surgery becomes extremely important. And this is the area where Dr. Rohit is going to touch on. I would just request Dr. Rohit to go ahead with the talk.
Thank you, Dr. Smith, PGI Alumni Forum, Dr. UP Singh, Dr. Arun, and all of you for giving me this opportunity. I will share my viewpoint. We can always discuss and debate. So we are all aware that a transcatheter pulmonary valve implantation is a surgical alternative for correcting dysfunctional RV outflow tract leakage or blockage or conduit obstruction, which is fairly common nowadays. We see and as the time increases, we are bound to see more and more cases, and we don't know the right answer whether we do the surgery or percutaneous valve replacement. As Dr. Suresh sir said, that in Kerala, they are getting operating top at 1 year of age, and after repeatedly they are saying more and more. Earlier, they would love to see them at 50, 40 or 50 years, but they are seeing at a much younger age. So I'll share my first two cases and followed by discussion. So this is a 56-year-old lady who had a 20 years back surgery for Tetralogy fellow. I would say great result by AIMS New Delhi. So she was operated at 35 years of age, background patch of VSD, extensive aortic resection with pericardial patch reconstruction. She was being evaluated about 7.5 years back since for this therapy, and finally she did manage to get some funds. In between this waiting period, she unfortunately developed significant RV dysfunction along with flutter. And in fact, 1 week before the procedure, she went into renal shutdown and she required 2 dialysis. We still went ahead and did the procedure for this. She basically had her major problem was severe PR with RA-RV dilatation and IVC dilatation and right heart failure. Her left heart was fairly okay, despite the right heart being dysfunction. So CT was done previously before she went into renal failure, fortunately. And this diameter measurement at pulmonary annulus and what is the branching pattern and all this can be well measured appropriately. You can see 3-dimensional structure that despite hugely dilated RV outflow, there is a construction. You can very clearly see that RV construction is there, and the fairly good distance is there between the construction point and the branching pattern. The branching, fortunately, branching pulmonary arteries are fairly good about that. So she was advised and taken for the thing. And you can see this, the multiple wires are going on this. What happened? So I think average diameter somewhere around anticipated diameter is 27, something like that. So we decided to interrogate balloon pneumoid balloon was used 30 into 5 millimeter. I will show you the next case. It is mandatory to assess the coronary artery, and we did assess in her. Unfortunately, I have not shown this. So you can see that balloon is inflated at 30, and you can see complete occlusal is there. We are fairly certain that we can take a wall in size of 32 millimeter bigger, so 32 mm. So you can see here this complete occlusal is there with the rapid pacing and this thing. So my wall was deployed with 32 millimeter. You have to have a CT analysis to see which view you are going to deploy the wall, and the decision of which view the RO cranial was made based on a CT projection. So 32 wall was deployed with rapid burst pacing, and we can see that post deployment. So we didn't send. You can always question me, and it is a debatable. The advice we got from Muthu Kumar and his support, he was fairly confident that we should not put a stent, but it's debatable, and there are data to suggest that if you put a stent in and then deploy the pulmonary wall, your long-term results are going to be better. In terms of power leakage and wall functionings are better if you put a stent and then deploy the wall. So to our surprise, it is said that if you develop RV dysfunction, patient may not recover or may not benefit, but fortunately for us, atrial flutter disappeared within 24 hours, and so there is significant improvement. And she did not require further dialysis, and we were able to discharge her. It's been almost more than a year or so, and with the trivial PR, she's doing excellently beyond our expectation. She's doing fairly well. Besides that, she requires a hypertension. This is a recent echo with a gradient of hardly any significant gradient, and she's doing fairly well. Second was the 25-year-old young male who had a surgery, as Dr. Suresh said, a surgery at 11 months of age. And again, the excellent surgery done at AIIMS, New Delhi, the Dacron patch VST with an RVOT resection. Fairly good results. And he had a second surgery at 13 years of age. With redo severe PR, the Carpenter Edward Paramount wall was replaced, and at 25 years of age, he started developing dyspnea and exertion. He's a fit chap who plays football, and he started developing dyspnea, and he was not comfortable. He had an ECG short first degree block with the QRS version of 152, and gradient has started increasing, which was not the case previously. He has a moderate gradient and a severe PR, and the rest of the heart was perfectly fairly good. Based on this, he underwent cardiac MRI, The volumes were not that typical indication for cardiac MRI, but he was fit and he was, you can say we could have delayed the case, but he was very keen that he should be allowed to gym, and he does severe PR was there, moderate PR was there. The volume, I will tell you the criteria for the volume. They don't typically fit into it. He still underwent the intervention. We discussed with him and offered him options. We only had, unfortunately, Merrill and Maiwal. Merrill Maiwal and this, what should I say, Medtronic valve. So he was very keen that he should have the Medtronic valve. So you can see we have integrated coronary arteries and done this one angio. And balloon integration was done to break the RV outflow tract with Thigh balloon. Then the MRI and CT was sent to one of the European center, and based on their assessment for this valve, to deploy 22 mm Medtronic Melody valve, we had to put 2 stents inside this one. Unfortunately, we could not afford a Sapien valve. That would have, we could have loved to put my valve or Sapien, but he insisted that I should have a Melody valve because that has the best result. So we ended up putting this first stent. You can see the first stent, then the stent in the stent, second stent, and then this was sufficient enough to deploy the. Sorry, this is a. You can. This is the wall was deployed successfully after this. And then after the wall deployment, you can see that he has no PR and his sodium. And we did look at the fluoroscopy to see the wall is well expanded and fairly good. This procedure also was done about, I think, June 2021. And he's looking fairly good, doing active gym, and he's fit and fine. He doesn't have any PR, and he's again graded is a single to 17/9. So, this was my third case we attempted. We could not deploy 32 my valve because there was still paravalvular leak, and we decided to withdraw the valve and abandon the procedure in this. So to carry on the topic of discussion, patients frequently develop RV output problem in a subset of patients who have an operated TOF or a truncus arteriosus in RV conduit or left-sided Ross procedure, or any Marcos blood cells requiring anything requiring RVT conduit would require would be suitable candidate for this kind of therapy. Severe PR also is another indication, and probably the most common. Pulmonary dysfunction can be because of the other problem like carcinoids and all this. They're extremely uncommon. Infective endocarditis can cause it, but unfortunately, this is a contraindication for doing percutaneous pulmonary valve replacement. We all know that pulmonary RV dysfunction is better tolerated than left-sided dysfunction. However, progressive RV dysfunction and RV enlargement ultimately does cause harm, fibrosis, and all this thing. And it also involves the left side heart because of the geometry, and ultimately leads to right heart failure, arrhythmias, and multiple issues. So we need to pick up early. That is why there are different guidelines, sets of guidelines. Well, I'm not very sure what exact is the cutoff. Different sets of will give you different guidelines for volumes for putting a percutaneous pulmonary valve replacement for 2 reasons. That it is said that if the RV dysfunction develops, it may become irreversible and patient may not benefit. So why wait for that? That may be the question. Of course, surgical reintervention is extremely popular and fairly common, and the more younger the child, more likely that he will go surgical intervention, and it gives you fairly good result for about 8-10 years, and it has been practiced and then fairly good result is available. So Philip Bonhoeffer was the first person to invent this therapy, and he used this Medtronic Melody valve in a little boy in RVT conduit with regurgitation. So based on what are the guidelines, in an individual who has trapezoidal fallow repair, it's with symptomatic severe PR would be class 1 with evidence of B indication for undergoing this therapy. Class 2 indication would be any patient who is relatively asymptomatic but has a ventricular dysfunction, or at least a moderate PR is there. There are other indications over there. Probably I will better go to criteria. So there are various guidelines people use as per their comfort and convenience. First guideline is Jiva. Most commonly practiced guidelines are European Society guidelines. They are better than American Society guidelines, but we can see that there's a slightly difference between European guidelines and American. So generally it is classified indication for the diastolic RV volume would be there is slight difference in all the guidelines. But overall, if you go by European guidelines, it should be more than 160 ml per meter square airway diastolic volume would be required thing. European guide, they don't recommend specify the systolic volume, but other guide like Jiva, they defined it. Ejection fraction is important thing, and there are other indications as well. So when you assess the patient, besides the symptoms, the dyspnea, NVH class, and it's equally important to assess ECG. If the patient has a very broad QRS ECG, more than 180 per second, he has a passive power, he may at a risk of sudden death, and you need to think and assess him whether it needs ICD or not. That needs to assess. So if you have a ECG abnormality which is significant, it is always or should halter or should be done. Cardiopulmonary exercise testing is routinely done in a large volume center. Unfortunately, we don't have. We are in the process, and it's likely to get very soon. Echocardiography always do it very frequently. Test of choice to assess the volumes probably is the cardiac MRI, but somehow we also end up getting CT because of the bifurcation and for unknown reasons. Some of the company insists that CT is required. Otherwise, large number of centers, chest of imaging of choice is cardiac MRI. Anatomical deletion is very important. You want to see where is there a construction, how length is where is the bifurcation, and what are the branching pulmonary arteries is there. This is feasible in a child who is more than 25 kg and bigger because the delivery systems are bulky, and also we don't have long-term data more than 10-12 years. The degeneration, these are bovine diseases. So long-term data are required. The more if you want to use in bigger thing. There is some ray of hope in aortic valve. Resilia valve for aortic valve replacement has some, but it's only hope, and we still don't have the answer for this. Some of the center use 3D rotational angiography to imaging and acquire the images and reconstruct a model. It's fairly good. It's upcoming, and then we do have a lab. Unfortunately, I was not. The lab was not given. The lab was not available that day, so I could not use that model. But we do have facilities, and we are likely to see more and more cases being done in 3D rotational angiography to define anatomy. And this is there. So there are some situations where you would not implant the percutaneous pulmonary valve implantation. So you will have some idea on a CT or MRI. If the coronary arteries are compromised or within 5 minutes integration of balloon valve, then you probably don't want to do that. If the balloon landing zone is too large, like we had one patient, we have borderline 30-minute annulus. We attempted 30 balloon, we simply could not block. We probably would have to put a 2 shunt, but that I think bifurcation was too short, so we could not land up deployment. So you also need to is there a landing zone? And because you have to have a 10 to 50% larger wall to anchor and stability there. If the patient has a previous infection, then you can't use this therapy. Better to go for surgery, especially in our setup in northern India. Drug abusers are fairly common in this situation. Surgery is also preferred option when additional interventions are required, say for tracheal valve repair. Significant tracheal valve repair is not going to get cured by pulmonary valve replacement. You have to address that. If you have to address that, why not open the chest and do both of them? If you require coronary bypass surgery, or if you have some aneurysm to resect to prevent arrhythmia, then it's better to send for surgery rather than percutaneous pulmonary valve replacement. So there are various valves available, Edwin Sapien, Melody valve. I think most tested and most talked about valve is a Melody valve from Medtronic. The Sapien valve is equally good, and Medtronic has launched the major drawback of Medtronic Melody valve was we could not use this valve more than 22. So Medtronic Harmony valve has come. I am not sure. I have not used. It's not available in market probably. The venous valve also has been launched and available very easily. Currently there are three valves available for this setup: Melody, Edward Sapien, and Merrill my valve is available for this. So the Melody valve is consists of bovine jugular valve. This is sutured into CP pneumatic platform. The valve was maximum size of 22. Maximum you can make is up to 24 mm. Beyond that, and it's generally crimped onto the big balloon. Is there? Current limitation on Melody valve is that you cannot use if you want to your annulus is beyond 22, 24 millimeter. So the Medtronic has come with a second valve for this valve. Edwards Sapien valve, on the other hand, it can be used in bigger sizes in the 23, 26, 29. So it's better, larger diameters in adult patient. This is more suitable and better preferred valve. Unfortunately, cost is significant and prohibits is used in this patient. So in India, cost factors is important issue. So Merrill my valve is fairly reasonably good. It's similar to Edward Sapien valve with some variation in design and delivery system. I think the size, you can see the both sides available in same sizes up to maximum. Merrill is, I spoke to Muthu, and Muthu is their advisor, and they are in the process of bringing higher sizes up to 34. It should come up in another 6 months to 1 year. Delivery system is a Python sheet is easily deliverable. So Harmony is another FDA-approved device recently for large RVOT, and it is fairly good diameter in 22 and 25 is available. It's a new invention. More and so you can see the more and more markets available. More and more valves are coming up for a better therapy. In this patient, they have about fairly in the 170 patients from ROT Conduit, 130 Melody valves were deployed. And what is the result? 10-year data is fairly good. In freedom from mortality is 90%. At 10 years, reoperation is 80%, which is fairly good. And for freedom from re-intervention is almost about 60%. Unfortunately, 10-year dysfunction is fairly high. As I think, as expected, as the biodegradable wall in pericardium patch would also degrade, so it's fairly high about that. The other advantage of this percutaneous therapy is that you can use wall-in-wall therapy, which is fairly safe and quite efficient way to do over there. Are there complications? Yes, you have to integrate coronary artery. You have to see that if there is any coronary compression, or if you feel that they are within 5 millimeters, then one should avoid deploying stent, and that you can all find out that by balloon integration is doing, you can find out. And then rotational angiography probably here would be fairly good to tell you, instead of taking RO and LAVO is there. Conduit rupture is, I don't have an experience of using wall in conduit rupture, but it's fairly reported, and most of the time you will be able to bail out with covered graft stent. So you have to have a CP or other, whichever stent you use, a covered graft stent should be available in them. Very rarely when ruptures, you less than 1%, you need to shift immediately OT. Generally, it is, I think more and more such procedure will be done in a hybrid OT rather than in a cath lab. So, we are currently doing in a cath lab, but more and more chances that such procedure will be done in a hybrid lab rather than a cath lab. Late complications are not uncommon, and it's been reported like a coax stent fracture has been reported in 5 to 16%. And the more younger the child you implant this valve, and the more higher the gradient at the end of the procedure, higher the chance that either you will have a stent fracture in higher. So young age, higher residual gradient is likely to give you more stent fracture in the thing is there. The stent fracture can be observed on X-ray also. You can see this, one of the struts is broken. And generally, simple stent fracture does not cause any problem. but the multiple stent fracture ultimately will enhance the degeneration into pulmonary recursion. Unfortunately, unlike the surgery, this procedure has a higher incidence of infective endocarditis compared to surgery, and it's been reported to almost about 3% chance that child or procedure will carry endocarditis. So one must be very meticulous and very careful. Precautions should be taken to prevent infective endocarditis. This technology has proven in exercise capacity, RV function, and pulmonary improvement, PR improvement. All this has been proven. The only problem is that at what early age we should do, because the younger the age you do, higher the chance of, like my second patient is a 25-year-old and melody wall. I'm very sure that 8-10 years down the line he'll come re-intervention and will require a wall-in-wall therapy. I would have loved to use the melody, my wall or sapien wall in him, but I was forced to reduce his diameter by putting 2 stents, which is not a good thing at 25 years of age for him. But then that is what happened. So if you have a younger the child, we are likely to get more the higher chance of degeneration and a higher chance of blockage are going to be there. To conclude, transcontinental pulmonary valve replacement is a safe, effective alternative to surgery for a wide range of patients in aortic conduit and back function. We still don't have the optimal timing for pulmonary replacement. It's a matter of continuing debate. We'll learn more and more, and we'll grow more and more. This is because there are some data to show that if the patient already develops severe aortic dysfunction, then chances of reversibility are less. And if you become very early, then chances of early degeneration because of that wall also both. So both way, it's a catch-22. If you do early, high chance of degeneration. If you do late, late recovery. So that is why we are still debating and we are learning and improving on what is the optimal timing of pulmonary replacement, and more refinements will come. Short and mid-term results are overall quite favorable and they're acceptable. As we learn, there is fairly good data on TAVI and aortic wall, and more data is coming. And there is a hope from Edward Life Sciences that developing wall, they're claiming, and of course, we will only know that after 10 years, their claim is correct or not. That some of the surgeons have started using Resilia wall, it's claimed to be very good, but we don't have the data of that. So future data is required. Will that translate into the pulmonary wall? We don't know that. It's too early. Sapien, the sapien wall, the large size sapien only had 3 years data. Well, so we don't have the long-term data for that. So future is awaited, I think. Thank you very much for the opportunity. Thank you.
Thank you, Dr. Rohit. I think that was an excellent review of the topic, as well as your own experience, which highlights the problems that you face while starting the problem in India. I think your very first case is an excellent illustration. You would have loved to do that case 10 years earlier, but the patient can't afford it. But fortunately, the patient's RV function is improving. So with all our predictions that beyond 160 ml, if you do, it may not recover. The brighter side is that it may not. It can recover is what you have shown. But we would certainly hope that we are able to, the cost is such that we are able to do it when we believe it is appropriate. Sorry.
I think cost is an issue. Yes, cost is
yes.
Not a, if you compare,
even my valve is not cheap for the 15 to 20 lakhs for a pulmonary valve replacement, and not as a one-off affair. This is surgery earlier, and for a reasonable number of procedures later. It's not something that people can easily afford. In fact, that in India, the choice of surgery versus transcatheter, certainly for an younger patient, becomes very important. You referred to the Inspiris Resilia valve. We have actually used it in pulmonary position now in 3rd or maybe 4th. Each of these cases, one was the young girl that I mentioned to you when we were chatting, 13-year-old pathology repair at 9 months of age. severe pulmonary regurgitation and aortic regurgitation at 8 years of age. At the age of 13, we are operating. We have given her an Edwards Inspiris Resilia in the aortic position and a Perimount in the pulmonary position.
Right, sir.
So those type of instances where you have no choice. Even then, it is much cheaper than transcatheter.
Absolutely. Absolutely.
The other case where I preferred that was a 27-year-old girl, tetralogy pulmonary atresia, recently married, came with severe RVOT obstruction. So we reoperated her and gave her an Inspiris Resilia. So 1 year later only, she's doing well. We are hoping that if the claims of the manufacturer are true, she should be at least able to complete her family during the lifespan of that valve. Questions that came up, Rohit?
Sorry.
Like there were some questions basically about choosing the diameter of the valve that you're going to implant. In the discussion, you can see that.
Okay.
How do you choose this is the size of the valve that I'm going to put in?
So I think basically you have a CT assessment. It's like same thing as a console as a pulmonary valve TAVI assessment. You basically have whatever the dimension you achieve. And then there are two issues you have to say. I think unlike the only person I think who doesn't use the stent is a Muthu. And if he is the proctor, I mean, then that is whatever data is there, the literature data is fairly good that if you use the stent and then use Melody valve, and if you then the long-term failures are slightly lesser compared to if you use only the straight-away stent, right? Valve without stenting, then the stent failure rates are supposed to be higher with Melody valve. So one of the reasons the Medtronic does not allow you to put a valve without stenting. You have to put a stent and then you have to put the further. They have data. They have the data to say that failure is good. So if you have to put a stent, so your RV CT will tell you, the software will tell you. This is what say example. My first patient, the 54-year-old lady, she has where I want to deploy the valve construction is about 27, average about 27 mm diameter. So we were not very sure we should have 30 my valve or 32 mm. So we integrated. It's only upon 30 mm volume. Even though CT said 27 mm, on the integration we will integrate with balloon sizes. And the 30 mm balloon, it was we were completely occluded. So if you had deployed 30, we probably could have a little parallel. So combination of CT along with balloon integration will give you the what size of valve you have to deploy in such patient.
Rohit, to transcribe that answer for the questioner, I think the question was specifically on what is the diameter that you choose. I think what you say is that the balloon diameter slightly exceeding it is the size of put it, correct?
Yes, sir.
And in taking the decision, you will use multimodality imaging to be certain, and finally rely on balloon interrogation.
Yes, absolutely, sir. Thank you.
Just commenting on the question of RVOT stent, I've had the privilege to work with some of the world leaders in this field in different places. All of them would use RVOT stenting. All of them. So I can understand somebody deviating from it, but you should realize that it is a deviation and therefore be ready for implications of that in the long term.
So what is the need and why can't we deviate? Or if we deviate, what is the harm?
The harm I can easily answer. One, especially the native RVOT. In the native RVOT, if you are not pre-stenting, you do not know whether your valve will sit there. After all, the native RVOT was not manufactured by God to house a valve. So giving a landing zone there guarantees that your valve will stay there. That is the most important thing. Second thing, the fit between the valve itself is a stent, no? The fit between the valve and the stent is much better than the fit between the valve and the native RVOT. That is the issue of paravalvular leak that Dr. Rohit was referring to. So the late paravalvular leak is also more with this. So as far as the developed world is concerned, RVOT stenting prior to this is a standard procedure. I would presume that we are trying to evolve as part of cost cutting. I don't blame people because 15 to 20 lakhs is no joke. And if you are doing a RVOT covered stent, it becomes another 2 to 2.5 lakhs. So people are trying to see how best you can cut the cost.
Good evening, sir. This is Dr. Ajay Swami speaking.
Hi, Ajay. Good evening. Good evening.
Rohit, sir, good evening. Fantastic talk as always, and really enjoyed it and enjoying the discussion also. I think what Suresh sir and Rohit sir have said is, and I think the practice, because it began abroad and because of the type of valves available, that was their default setting, and they have never deviated from it or looked away from it. I think the current generation of balloon expandable valves, the problem is to get a reproducible and standard RVOT and to get a beautiful landing zone. Whenever there is an issue with the landing zone, I think that is where the stent comes in handy. The issue of paravalvular leak, sir, has already discussed, so we will not add to it. But that's my two bits in the sense that in the appropriate anatomy with the correct measurements and the correct landing zones, I suppose it is possible to do it without a stent. But in all situations where these three criteria are not met, it's always better to put a stent because you can predictably place the valve where you want it, expand it to the size that you want, and you are confident that you have given a well-functioning valve with no long-term outcome. I think these three questions need to be answered before we decide whether to put a stent or not.
I think, Dr. Ajay, what is your take on, we are not sure. What Melody Wall is saying is that they have a data to say that if they have stented and then deployed the valve, then if they have not stented and then put a Melody Wall, the long-term complications are better with the person with stented and Melody Wall, right? We don't have data for the my wall. It's just too early for that.
Yes, my case is that. Sorry. Please
I was about to say, I was just highlighting what Dr. Ajay said. As your experience accumulate without stenting, then you will be able to say, that this is the complication rate if you don't stent over a larger number, over a longer period of time. At this point, whoever says is after a few cases, seen over 6 months, 1 year, or 2 years. So this is where in accepting that as a validation of a strategy, we need a little more evidence, like Dr. Rohit said.
Yes, sir. But no, my only issue was that when we have
to cut down the cost and to improve the procedure in all possible. I'm sorry, Dr. Ajay, please go on.
No, sir. Perfectly all right. I'm sorry to interrupt. So what I was saying was that I think in unselected series of patients, it is obviously better to put a stent when you're not sure. But as we learn more about the anatomy, if we are able to identify the landing zones, predictably decide the size, and be sure that the valve is going to sit where we need it to, I mean, that comes with time, but these are not so difficult actually. As you start evaluating the CTs, probably you can make these decisions with time. It's just that earlier these inputs and this kind of imaging data was not available. It was just unselected patient series in whom the stent was placed and then the valve was placed. But as time has gone on, now we have started looking at these things. And I think when we have data for these, probably this is what I see the future. That, putting a stent has got its own issues, and kind of one person kind of, you overdilate, and the issue of coronary obstruction, which is actually the elephant in the room as far as putting a valve in the pulmonary outflow is concerned, that you really need to be very, very careful that the coronaries are not going to get obstructed, because most of these patients are post-surgery. Most of them are, many of them have anomalous coronaries. So that is a very, very important consideration. In these situations, I think the anatomical considerations with better imaging will probably give us an answer. Unselected, if we are doing, I completely agree with what the data is. We need to follow the data as far as possible, but we need to think beyond and transcend it also. So in a given patient, I suppose it's possible.
Coronary compression, of course, is a very basic responsibility of the operator to guarantee that it doesn't happen. So spending more time on evaluation than on valve deployment is a very, very useful thing.
Good evening, Rohit sir. Wonderful presentation.
Hi, Saurav. Good evening.
So my doubt is, like, in younger patients, is it better to send them for surgery because they need more and more intervention in future, like putting transcatheter pulmonary valve replacement in younger age? After 10 years, patient needs again one more valve. So
I think so. I think I would prefer surgery.
okay. And so surgery definitely, regarding the cost, surgery is definitely cheap in India as compared to
Correct.
And so, do we have any data regarding that? Because in surgery also, we are also using the bioprosthetic valve.
I guess Dr. Suresh can give a better answer than, or Suresh and Ajay can give a better answer. But in our center, Dr. Sham Thignam, he doesn't use the. I mean, he uses pericardial, he reconstructs the wall, and acute results are fairly good. We don't have long-term data, but acute results are fairly good. Something like what he has done a lot of Osaka procedures in adult, and adult results are absolutely fantastic. He's done about 150 Osaka procedures. He's similarly trying to replicate into the children with some of the things, and they are acute results. We simply don't have the long-term answer.
Thank you, sir.
Answer that. I have a fairly large experience on dealing with pulmonary valve regurgitation with surgery in the young child. If you are reconstructing the valve at the time of repair, that's a great thing. As part, now that surgeons are more and more aware of the implications of a competent pulmonary valve in the RVOT, more and more surgeons are taking pains to do something to the pulmonary valve. There are a number of things that can be done. But if you are dealing with severe pulmonary regurgitation in an young child, doing a repair surgery in general has not been very satisfactory, not only in the personal experience that I have seen, but sort of across the country. What we would like to do, we have had quite a few cases in that, is to give a bioprosthetic valve. The bioprosthetic valve, the problem, the younger the child, the greater is the calcification rate. This is where the Inspiris Resilia people say that they have a different anti-calcification strategy. Now, we have employed Inspiris Resilia in a few people. The youngest child is 13 years. The oldest that we have employed is 40 years, because across the age spectrum we have done it. If it lives up to its expectation, they are saying that it will last 25 years. If it lasts even less than that, that's certainly better than trying to give the child, like you said, as a percutaneous pulmonary valve and have it replaced 10 years later. Not only in terms of the durability, but also in terms of the cost. So my center's practice is to give a bioprosthetic valve. I have at least 3 patients who have completed 15 years on regular perimount valve. So given a choice, my option will always be for a bioprosthetic.
I think to add to Dr. Suresh's question, the perimount valve gives fairly good result. I have a patient, 6-year-old male, from operated 20 years back at AIMS New Delhi with perimount in pulmonary area. At 20 years after that, he degenerated. So it's perimount in. The question is, if he is now 6 years. For the same patient, if you operate at say 10 years, then that's where the problem is. Otherwise, at older age, results are fairly good.
So, sir, how to decide which patient to send for surgery and which patient to send for? Or only the age, or it's also the RV function?
I think you'll have to speak to your. It depends on center to center. Your center is very good. Dr. Devaguru is a very good surgeon. Not only Devaguru, there are other surgeons all over. I think it depends on center to center, and you have to with cardiologists and center cardiologists survey. We tend to smaller the children. We tend to go more and more surgery.
Thank you so much, sir.
Again, say 40-year-old doctor, post pulmonary valve replacement. He's asking you this question: shall I have surgery or shall I? Money is not a problem. Now, I offered him, you have an Inspiris Resilia now. Hopefully by the age of 60, you can have a percutaneous valve, in which case you have had only 2 procedures.
Yes.
But a 40-year-old man, if you are looking at a lifespan up to 80, how many procedures should he look forward to? So this is a very difficult question to answer. While the Western data will all tell you, you do 5 interventions, it doesn't matter. People will not take that.
I got
And
it, sir.
even Perimount takes a valve-in-valve transcatheter valve.
Thank you, sir.
Inspiris Recilia has the stretchable struts. Inspiris Recilia is actually meant for the aortic position. It is expected that at some point somebody is going to put a transcatheter valve there. So the struts expand. So you have the added advantage of being sort of pre-fabricated for a valve-in-valve.
So there are a few more questions in the chat box.
Are there?
Why pace low pressure system, and why do we need rapid ventricular pacing? And when also there is no risk of CHB after implant.
I think CHB is not an issue. I don't think CHB is an issue in such patients. We do rapid ventricular pacing to reduce the cardiac output and stability. You just won't want misplacement.
Was there any other question? I thought you had answered all the questions.
Why diameter beyond the diameter of the conduit? The balloon dilatation, pre-balloon dilatation should not be beyond the diameter of conduit.
I think Dr. Suresh can answer this question.
Yeah,
I don't have any.
You can actually go beyond the size. Like, for instance, I had a child with a 16 mm conduit. We managed to put an 18 mm melody in that. This was done in the US. But it is possible to stretch it as long as, mind you, one, you have a covered stent. So you know that there is a problem with the conduit. You have an insurance. And we are trying to put a Medtronic melody valve. The smallest is after all 18. So you need to create a landing zone for an 18. So it is possible to go beyond a few millimeters beyond the size of the conduit, provided it is stretching.
I think, sir, that answers most of the questions. And being new for everyone, I don't think we do presently have any questions. And I guess Rohit sir is always a phone call away. Whenever we have question, we can always approach him. And the same for, I hope, Dr. Suresh Kumar also, we can trouble him anytime. So next month we will be meeting at India Live, hopefully at the dinner on 16th, walkable distance from the main venue. And 16th is our dinner, and 17th is dinner hosted by India Live. So let's hope, sir, we'll discuss the constitution if any amendments are to be done, because while getting it registered, I need to have a set of rules for the registration office. So I basically made those rules and got the procedure done. And now if we find that we can amend, and there are many suggestions of like starting registries, different registries. So probably young people like Saurabh or Sumit, they can take over lead and collaborate to get data and have some good publications coming out from our group. Because we all are doing so much, lot of good work, and it is going unnoticed.
Once again, I want to thank Dr. Smith and alumni, and it was a honor and pleasure to see Dr. Suresh chairing the session. Thank you, sir. Arun, UP Singh, sir, all of you, thank you so much. And Ajay Swami, I think one of the leading cardiologists now in structural heart disease and coronary. Thank you. It was honor and privilege to speak in front of you. Thank you so much.
Ajay has got the Benjamin's button case.
So thank you all for a nice. We'll catch up in India Live. Thank you. Thank you. Good night.
Good night. Good night. Night, everybody.